It's an honor to be able to sit next to both Tiffany and Solaire and present what we're doing and working on with the intervention called Teen Birth. So I'm going to tell you a little bit about the history of teen birth. It was established in 2018 with a pilot trial originally in 4 hospitals, and then I'm going to share with you how far we've come, but also what the program entails. We are part of Ariadne Labs. It is such a tricky word to say, but our founder is Dr. Atul Gawande. Who in here has heard of Dr. Atul Gawande? Okay, good. We'll talk about him in just a moment. But we're a joint system of healthcare innovation between Harvard School of Public Health and Brigham and Women's Hospital. So we're not a lab that is researching new pharmaceuticals or medications or new procedures. It's really, we're trying to understand what we call in healthcare the no-do gaps, what we know we ought to do, but the gaps in our healthcare system that prevent us from doing the right thing for every patient every time. So as I mentioned, Dr. Atul Gawande is the founder of the Checklist Manifesto and also the World Health Organization Safe Surgical Checklist. So if your hospital is Joint Commission recognized, it is very likely that you yourself participate in some of the tools that have surfaced from Ariadne Labs, and it is the power of the pause. And the reason I wanted to mention that as a critical foundation is because if you yourself have been in an OR and you've used the Safe Surgical Checklist, my hope is that you see the bridge and the parallel, there are commonalities between the two and what we aim to achieve and in the process with which we do it. At Ariadne Labs, we work with research scientists, PhD, DNP, doctors, doulas, nurses, community partners, patients. I also have with me our Chief of Staff, Tyler Fox, who we have a table in the back, so if you have more questions after our presentation, please feel free to stop by. We are working currently in the state of Tennessee with 5 hospitals, and I do know that perhaps they were mentioned this morning, but I can't help but to recognize them again. We've been working with them since January of 2024. We've been doing data collection pre-implementation and post, and we are concluding that partnership as of this month, which is very sad. So if you don't mind, as I call your names, I would love for you guys to stand up. So Ascension St. Thomas Midtown in Nashville, Tennessee. There you are. We're also working with Regional One Health in Memphis. So all you girls with your teen birth t-shirts, stand up. Also, we are working in Savannah with Hardin Medical Center. The University of Tennessee Medical Center Knoxville, that was a previous implementation partner in 2022 with the March of Dimes. So I also want to recognize them. They led the way in Tennessee. And last but certainly not least, we are also currently working pre-implementation efforts with Baptist Medical Center. Are you all here as well, Baptist? So I know there's already been a great deal of discussion about where we are really in our country with our severe maternal morbidity and mortality, but I do want to put an emphasis on this bottom. In 2023, the CDC released a national survey, and 45% of mothers and women reported holding back from asking questions, sharing concerns or symptoms with their healthcare teams. The reason for that is fear of retaliation, judgment, being deemed non-compliant. And so rather than speaking up, advocating, and being empowered, they shrink and they become quiet. And what we're aiming to do with Teen Birth is really center patients in their care so they feel empowered as an active participant and not a passive recipient of their care. And we infiltrate the healthcare system at the hospital level. So really this tool is meant to be, it is designed to work from admission to discharge, labor and delivery to postpartum care. Additionally, we know that the Joint Commission reports that when sentinel events happen, it's not because that blood bank in rural Tennessee did not have blood, right? That's not usually the cause of a maternal death. It actually is a root cause failure in teamwork and communication. So that's where we really started this journey in 2016, understanding what are those gaps in teamwork and communication. And it's not just simply between clinician to clinician, right? It often is patient their lived experience, their symptoms, feeling empowered to share their experiences and their knowledge in the moment so that it is an integral part of the shared decision-making that occurs. So the purpose of this is that we all come to a birth experience with our areas of expertise. And I also want to really elevate the area of the expertise that a patient brings when they bring their support person, but most especially also their doula. And I'm going to go into that a little bit more. But the bedside nurse is the eyes and ears for that provider, monitoring those strips and sharing back updates along the journey of birth and then in postpartum as well. The patient themselves, but also the provider and their clinical expertise and the management of that patient. And so what we're aiming to do with this teamwork and communication structure is to ensure that nobody's expertise lives in silos, that we come together as a cohesive team at the most critical moments in a patient's birth journey. So the tools and principles in the design of team birth, I do want to mention for one very specific reason. It's not hard, but it is difficult. It's a very simple concept. It was rooted in teamwork. So how does it benefit everybody? Not just simply clinician to clinician, but the patient as well and their support team. And in simplicity, because we know that if we create complex solutions, who will do them? Nobody. The healthcare system is already so complex. So as I go through this presentation, if you think, well, that's simple, that's a victory. We had that in mind. That was a goal that we aimed to achieve. So these are the two core components of team birth. One is a series of team huddles, and I want to put an emphasis on this structured communication. The structured communication lives and sits on a shared planning board inside of the room. And what happens is when you bring together a communication board that has to be updated and is a space for teams to come around together, then communication all of a sudden becomes a top priority in the clinical management of that care. And so the second core component of team birth is designing and anchoring a shared planning board in the room. Your patient, their support person, their doula can write on it, and they're invited to just as much as the clinical team. So this is common communication structures that we have really in all disciplines of medicine, not just exclusively in obstetrics. But what we see here is you have your patient, the bedside nurse does an assessment. So long as everything's going smoothly, there may not be any triggers for a concerned follow-up call or conversation with the provider. However, if something changes, what happens? The nurse leaves the room, goes to the nurse's station, the hallway, calls the provider, shares the S-bar, gets the orders, goes back and translates to the patient. Well, we all learned in elementary school, right? The game of telephone, what happens? Things get lost and missed in context. And sometimes those are really, really relevant components. And so with the team birth model, what we're aiming to do is change the location and environment of that conversation so it is happening transparently with the patient at the bedside so they are centered in that communication and conversation. So there's 4 key behaviors for team birth. Number 1, just promoting the team. Who's on the team? What is your role? It is a super simple, basic concept, but I will tell you how powerful it is for patients, especially when you're in an academic center and your patients may not fully understand what is the difference between a medical student, a first or second year resident, a fourth year resident, and attending. There's a lot of confusion. If you're a hospital that provides nursing academic preceptorships, is this a nursing student? Who's my nurse? What's the difference? So really helping delineate the roles of everybody who's in the room, who is the critical key decision makers, but most importantly, our emphasis is on the captain of the team is actually the patient herself and whoever she brings with her. This is the moment where we really try to break down silos and walls where there has been historical disrespect with working with doulas by first and utmost in the admission process, acknowledging them as an integral member of the team that brings expertise and that we're grateful to have you here. You make our lives so much better and we're gonna make this birth experience even more centered around this patient and hopefully her preferences. So that brings me to the second key behavior is patient's preferences and eliciting those on admission, but also at key intervals throughout birth and postpartum. So one is really understanding what are the concerns, the hopes, the fears, the things that are well understood, maybe some of the confusion or misunderstandings, clearing those up from the beginning and understanding what is the hopes of this patient. Are they low risk? Are they high risk? If they're low risk, can we honor some of those more homeopathic physiologic birth requests, should they have them? But really slowing down to understand. And then the third is creating care plans that validate, acknowledge, and honor those preferences when able. This is where we really enter into that shared decision making. So it is not a linear conversation. There can be some negotiation depending upon the circumstances and the clinical manifestations of that patient. But really laying out, here are the options. You're 5 centimeters, your water broke, you're low risk. What are your preferences? You want a more physiologic birth, low interventions? Here's what we can do. We can start with nothing, nipple stimulation, Pitocin, breaking your bag of water. And then you go back into that negotiation process and really re-elicit patients' preferences so you arrive at shared decisions. And then the final is just helping close the loop of when we anticipate that the team will come back together. I know me personally, I often didn't fully always appreciate that patients didn't understand exactly the workflow that we do day in and day out. That is second nature to us. And often there's misconceptions, right? Like my OB is just sitting right out in the nurse's station on pins and needles, waiting for anything should happen, they're gonna swoop in. That's not the reality that we live in, but our patients don't always know that. So really helping close that loop, providing those expectations, decreases anxiety, and provides a lot of transparency and clarity. So if you're thinking, what are those 4 key behaviors and how would I remember that for every structured conversation? It lives right there on the shared planning board. It's a visual tool and a visual cue and reminder. And I am gonna share, because we do go through in the implementation process, we co-create your boards with your teams, so we go through a design process. And so for today's presentation, I wanted to elevate, this is Hardin Medical Center's boards that they designed, and this hangs in all of their rooms. And I just want to put a plug in that Dr. Harmon, one of their providers, will be speaking tomorrow about their implementation and experience with this intervention. Additionally, we have 2 shared decision-making tools. When to admit, so this is an admission discussion guide that really lives in OB triage. We really recommend for teams to actually turn this into a poster or make it very visible to patients. And really it's meant, not for the black and white. If you have that mom that's 8 centimeters, you would never utilize this tool, right? You just rush her over to L&D and do what you guys always do. But it's really meant for those patients in the gray. Prime up, who is 2 centimeters, contractions are irregular, she really wants to stay. You all know that there are risks associated with going and getting admitted, being in the bed on monitors, more at risk for interventions, and then ultimately also more at risk for a C-section. So if you're making that clinical recommendation, she lives close to the hospital for discharge, or she lives far from the hospital, maybe there's a mall that she could go to, or a walking path where she could continue to move, continue to eat and drink, have the comforts that she desires, then this really helps guide that. Additionally, what this tool also provides is it provides the clarity that you are giving non-biased care. This is the pathway that we provide for all patients, and so this is the clinical recommendation that we're making upon your circumstances, not the color of your skin, your medical literacy, your knowledge, or your language. The second one that we have is a labor support guide, so it really does help provide the patient with what can you and your support team do to help in the labor process, in the birth process, versus when would you like for the medical team to intervene, and what are some of those tools in our toolbox. And then the third is an assisted delivery discussion guide. During the pilot trial, I myself implemented team birth from the hospital side, not from the support of Ariadne side. And we saw a tremendous reduction in our NTSV scores, and I would say and attribute a lot of it to the utilization and successful implementation of this tool. Because what this tool does have on it is simply ACOG and SMFM guidelines, but it is written in patient-friendly language. And whenever we have done patient focus groups, what we have heard time and time again is it is a complete mystery to me as to when, why, a provider or a clinical team would recommend a transition from a trial of labor to a C-section. So this provides that very clearly for a patient. And the goal is to really help it validate your clinical team's recommendations. So the patient again sees this is a recommendation rooted in the clinical manifestations of your situation, not anything else. And it brings them through that journey so they understand my team did everything that they could, and I feel really reassured with the decisions and outcomes that we made. All right, so that is a high-level overview of what our program is. It's a simple concept, but what it does is it does change culture. It is a behavior-based quality improvement, and that's hard work. It's very different than skill-based quality improvement. So typically we go through a journey of implementation support. I've been personally on phone calls with these teams of the hospitals for the last 14 months, helping coach them through an implementation pathway and then post-implementation support. But a big element of what we do is data collection from the patients themselves. And what we collect are patient-reported experience measures. So the majority of the data that I'm going to share with you today is from PREMS. However, we do have a little bit of clinical outcome data, and we're currently in a partnership with the state of Washington on a 3-year research project to collect clinical outcome data. So our hope is very soon we'll have more of that outcome metric to share as well. Currently, we have 5 publications. 3 are from the pilot trial in 2018 to 2019, and all 3 of those are in the journal Birth. We've also had 2 additional manuscripts written for OBG management. We're currently also in the midst of a manuscript for the state of Oklahoma, which Dr. Graves alluded to and mentioned, and I'm going to share some of that data today. That was a 3-year research partnership. So from the pilot trial, it was an acceptability feasibility trial. Did clinicians like it? Would they do it? And did patients like it? And what we got was an over-resounding positive feedback. 97% of patients reported that they had the desired role that they wanted in their birth experience. 98% reported clear communications with providers, but also the ability to share their care preferences. And 90% of patients said when they shared their care preferences, they were acted upon. They were honored. And then from the clinician side, 93% felt that it improved care for their patients, 90% said they would recommend it to another L&D unit, and 84% said that it helped clarify C-section decision-making in non-emergent situations. Again, these tools and resources would never be used for that abruption, that cord prolapse. It's really meant for more of the gray when there's time. So I'm going to share a little bit of the data from our most recent research, which was with the state of Oklahoma. This is 6,528 completed patient surveys. The data collection began in September of 2022 and concluded in June of 2024. And we established 32 IRBs with hospitals all across the state in order to be able to do this data collection. I'm going to share with you, I wish I would have brought more data because one of the tools that we used was a validated tool called the Healthcare Relationship Trust Scale. I didn't bring that just because of the condensed short presentation time parameters, but I'll share some of that. What you're seeing here is the utilization of a tool called MAD, Mother's Autonomy and Decision Making. This was a tool that's been validated globally, so that's one of the reasons that we chose to use it. It also, though, is very sensitive to the teen birth behaviors. And so what you see along that x-axis are the questions themselves that we ask every patient. And what you see in the orange is patients who are stating, no, I did not receive a teen birth huddle. And in blue, yes, I did receive a teen birth huddle. And what you see is a dramatic increase across every domain. They felt more involved in decision-making, informed about options, explained pros and cons, helped understand information, able to choose best option, and that choice was respected. But we also care very much, again, as we should in the US, about the disparities that we see in our care. So we wanted to understand this data. And so what you see here along the x-axis is Hispanic, non-Hispanic, Alaskan Native American Indian, etc. And it's showing you the PREMS reports based on race and ethnicity. Our highest was areas of improvement were for our non-Hispanic Asian. And in the state of Oklahoma, there is a very large Native American population. And so that was the second highest domain of the mother's autonomy and decision-making was for our non-Hispanic American Indian. We also, as I mentioned, utilized the Healthcare Relationship Trust Scale. It's a 13-question validated tool. And what you'll see if you read the manuscript when it comes out is actually our highest domain of improved trust between a healthcare team and the patient was for our non-Hispanic Black African American patients. I also want to share and show some of our clinical data. Now, this data is shared with us from Akron General Cleveland Clinic, and they have given us the permission to share this data. This is looking at their NTSV rate, and they had been doing a couple of different projects to really reduce NTSV. So where they started was an overall NTSV rate of 29%. You can see that they implemented Team Birth in 2022. They did also implement an anti-racism bundle in conjunction with the implementation of Team Birth. And then in January of 2024, they saw a great reduction down to 23%, and they sustained. But there's more to that story, because whenever they broke down the data by race and ethnicity, what they found was they themselves had very large disparities in their NTSV rates. 41% was their NTSV rate for non-Hispanic Black African American women. And it was 27% for white women. After implementation, they saw a leveling effect, and actually the reduced rate for Black women was even lower than white women. They were very proud of this efforts. They continue to monitor this. They have continued to sustain it, but they attribute that success to the implementation of Team Birth, and so they give us the privilege to share it. All right, so I want to share a little bit of feedback, of course, with what do patients have to say. We do all of our postpartum surveying inpatient, so it's a survey that they receive postpartum day 1, and then they provide it back to the clinical care team in a sealed envelope prior to discharge. We also do all of our patient surveying by paper because that gives us our greatest response rate. For whatever reason, QR codes are just unsuccessful. If anyone in here has ever had success with QR codes and patient surveying, come talk to me because I want to learn your ways. We have about a 5 to 10% response rate with QR codes. I think my hypothesis is it's object permanence. If you're starting a survey and then mom texts and you send a picture of your baby, very unlikely to return to it. And that's what we see. Patients start but don't finish. So all of our surveying is done by paper and in the postpartum period. And this is what patients themselves have to say. My preferences were heard and acknowledged. I knew what was going on and what I preferred. My preferences for my delivery were always respected. I never felt pressured into any decision for care, even as the conditions changed. Answered questions were super respectful and honored our thoughts, opinions throughout the whole process. I was so very appreciative of how the whole team cared for me as a whole person. You cared about how I was feeling, and by doing so, you made me feel human and relieved my fears and anxieties so I could make informed decisions. That's just a few, and it's really overwhelming and remarkable. You can ask the hospitals that are implementing. Some patients write paragraphs because they really do want to share their experiences. It is such a monumental time in their life, as you know. And then providers, this is some of their feedback. For vulnerable populations, by being able to communicate and ask what we're doing, it brings the standard level of care to everyone. So it decreases some of those implicit biases that we have. The board is a helpful cue. There are disparities in the communication problems that occur between the care team and person giving birth, and this kind of problem happens too often in healthcare. Part of this problem is implicit bias, which is associated with lower quality of care for patients. There's something about that communication and decision-making when the provider and patient are doing that together. That creates a whole new foundation of trust and dignity, and we know lack of trust is a major driver for why Black pregnant patients do not seek care or do not engage in care. So I wanted to share a little bit about our program. We are hoping to continue to partner with additional hospitals throughout Tennessee. And so as those opportunities surface and Brenda comes knocking on your door, please consider our implementation support. It is 2 touch points every month. So it's not like an AIM bundle, honestly, where we give you the information and then you go do it. We truly try to help support every step of the way, from socializing the project to training all of your clinicians to implementing and sustaining. So we would love to answer any additional questions that you all might have. Do I have 1 minute?
No, we'll do it at the end.
We'll do it at the end. That's all I have for you today. Thank you guys so much for your time.